Welcome to Deep Dive Dialogue, where curiosity meets conversation, and every episode is an exploration into the extraordinary. Today, we have with us Dr. Anup Rawal, and he is here to discuss with us innovations in genetic screening from newborn to prenatal diagnosis. Dr. Anup Rawal is a senior consultant, clinical and cancer geneticist with over 12 years of experience. He is serving as the Associate Director of Medical Genomics and Genetics at MedGenome Molecular Diagnostic Lab. He is passionate about bridging the gap between genetic research and clinical practice in India, aiming to improve patient outcomes. He excels in diagnosing, treating, and preventing genetic diseases and cancers using advanced technologies. His core competencies include precision medicine, medical genetics, cancer genomics, and reproductive genetics. He is also actively contributing to academia as an adjunct faculty and panel consultant at MUHS NAS. Welcome, Dr.
Thank you for the kind introduction, ma'am. So, hello everyone.
Yeah. So, please tell us, Dr. Anu, what are the advantages of newborn screening as far as rare genetic disease are concerned?
Let us first understand what are rare diseases.
Yes.
Usually, there are different definitions which different countries have adopted for defining what are rare. So, and it's different in context to each country. Like in US, any disease condition for which cumulatively there are less than 2 lakh individuals, that is the criteria. In Europe, they say anything which is less than 1 in 2000. So as such, in India, we don't have any specific, cutoffs or guidelines. But rare disease, then it becomes something difficult to quantify.
Yeah.
So when we're talking of newborn screening, what is the principle behind newborn screening? So the principle behind newborn screening is to identify conditions in the neonates which have not yet manifested and which are possibly treatable, curable, and all the associated complications are avoidable. So there are general criteria which we follow to decide what disease conditions can be screened for. So mostly we are screening for inborn error of metabolisms or certain conditions like say congenital hypothyroidism. When if diagnosed early and treated appropriately,
Yeah.
all complications and sequelae can be totally avoided. So if you talk of rare diseases, now rare diseases is a very blanket terminology. More than 8,000 such disorders have been catalogued, and almost like 80-85% we know have a genetic etiology to it. So it will include a huge spectrum of conditions, right from neurodevelopmental, structural anomalies of the brain development, of the development of the spinal cord, vertebra, skeletal system, heart, so on. And in that, inborn error of metabolism is one spectrum. Other metabolic conditions like lysosomal storage disorders, mucopolysaccharidosis, and so on. So if you talk in terms of management for rare diseases, hardly 5% have upfront cure or treatment or therapies that are available.
Okay.
And for a chunk of them, trials are going on, research is going on. So the advantage in this situation is if we can, the same rationale as we apply for inborn error of metabolism, if we can diagnose or pick up the conditions earlier in the neonatal life. Because for rare disease, the average time duration from the development of symptoms to diagnosis, which has been shown globally across various countries, and studies have shown that the average time taken for diagnosis is like 5 to 8 years, which is huge.
Yeah.
So then if you're screening for rare disorders in newborns, if the suspicion is high, particularly those conditions for which the population frequencies are more compared to other conditions,
Yeah.
then screening for rare diseases makes more sense. What is more important is if you're screening for a spectrum of conditions that I talked, routinely we do newborn screening by a technology what we call as mass spectrometry. And that is, we take a blood drop by heel prick of a neonate on a filter paper, and we analyze the analytes or say substrates or the enzymes by mass spectrophotometry.
Right.
And whatever parameters we get deranged, then there is a screen positive for those particular conditions, and then we subsequently suggest confirmatory testing for these children. And confirmatory testing is usually genetic.
Okay.
If you talk of the spectrum of rare disorders where you have skeletal dysplasias at one end, structural abnormalities of organs like say brain, vertebra, spinal cord, heart, kidneys at other end, and there could be syndromic where multiple organs are affected, and then one chunk is IM.
Yeah.
So when you're talking of metabolic errors, those can be picked up by doing a mass spec based test.
Right.
But for rest of the rare disorders, then this screening won't be possible.
Yeah.
So this tandem mass or mass spec based test won't pick up those abnormalities.
Yeah.
So what happens is, in these situations where genetic etiology is known, doing a NGS based test will make more sense.
Right.
So something like a targeted panel, NGS panel maybe, or maybe you do a whole exome or whole genome sequencing. So these are sorry.
Yeah.
So maybe you do whole exome or whole genome sequencing. So these are various options that are available. So right now, there are no strong recommendations or guidelines which suggest that upfront we should go for NGS-based screening.
Yeah.
But yes, lots of research is going on, studies are going on, which show that if we do a NGS-based screening test,
yeah,
the yield is up and above the limited screen that we do based on the mass spec test.
Yeah.
So that is the advantage of doing a NGS-based test for rare disease if you want to screen the neonates. And just to point out, like individually, each of these conditions may be rare.
Yeah.
But cumulatively, these conditions are very common, and even the Indian policy say it like 2 to 4% they say of the population could be affected.
Okay.
Now looking at the large Indian population, so this cohort could be huge.
Right. So I've got the future perspective of NGS, I've got the technologies. So I would like to ask you about NIPT. Can you explain that how NIPT is expanding the scope of prenatal genetic testing?
Yes. So very, very nice question. So non-invasive prenatal testing.
Yeah.
So basically, any couple planning pregnancy, there is always risk of chromosomal aneuploidies in pregnancies.
Yeah.
So this risk of chromosomal aneuploidies, the common ones being 21, 18, 13 and 6 chromosome related aneuploidies, it increases with age, more significantly above the age of 35 for females.
Yes.
But if you see the incidence or the babies being born with these chromosomal aneuploidies, paradoxically, more children are born with to women with younger age, because more pregnancies are happening at a younger age.
Yeah.
So that way, the risk is significant. So the traditional screening methods are, we do maternal serum screening, and fetal scans, NTs. But again, these are screening tests and they have sensitivity and specificity combined for say NT scan with the maternal serum markers could reach as good as like 85-90%. But again, these are screening tests, so there are lots of could be false positives. That means more females actually who are not having chromosomal aneuploidies, they're undergoing invasive procedures like amniocentesis, and then we do tests like QF-PCR or FISH test to confirm is there a chromosomal aneuploidy. So now this is important. Unnecessary invasive tests are being done. Now herein comes the role of non-invasive prenatal tests or prenatal screening. So how does it, what is the principle behind NIPT? So here we are doing the test on maternal blood.
Right.
So what happens is once the lady is pregnant,
Yeah.
there is a fetal cell-free DNA component which comes into the circulation of the mother.
Yeah.
Now this happens because of the trophoblastic cells at the placenta which undergo apoptosis, and because of the hyperdynamic circulation, those cells, their DNA comes into the maternal circulation.
Right.
So the separation or identification of the cell-free DNA component from the mother and from the fetus is done based on the length of the cell-free DNA component. So there is a difference in length based on which we can identify. So now what we do is we do next generation sequencing based test. We pick up this cell-free DNA component, do massive parallel sequencing, amplify it, and then we map these fragments across the reference genome, and then we compare, okay, which area more reads are found and which area the reads are, there is a variation. So suppose we have 23 chromosomes, so we are concentrating on the 5 common aneuploidies, 21, 18, 13, X and Y, and we check where the reads are, there is a variation and what is the ratio. Yeah. So that gives us an idea. Okay, say like for chromosome 21, the ratio is skewed. It is pointing towards one extra chromosome 21. So that is how the testing is done. So this is just to simplify. Then what matters is which platform is utilized to do the test. So accuracy is better with Illumina platform. Some labs are utilizing platform like the Thermo Fisher, that is also equally good. Then what are the guidelines? So the recommendations from ACMG and ACOG, they suggest that we do screening for the 5 common chromosomal abnormalities. Right. And there is a recommendation to do for microdeletion, that is 22q. So that is one of the recommendations. So there are a lot many labs who do additional screening for other chromosomes and other microdeletion syndrome. So that's an optional test. That's an add-on, but there are no standard recommendations to support that or evidence to support that. Okay. So next generation sequencing based NIPT. Now let us look at the accuracy of this test. Yeah. So as we saw earlier, maternal serum markers, the accuracy, if you combine with the scans, it may go as 85-90%. For NIPT, the accuracy for picking up trisomy 21 is way above 99.7%. So that's the sensitivity and specificity. Okay. So, and what is more important is the negative predictive value is very high. So that means if the test is negative, there is a bleak chance that we are missing anything. Of course, there have been some case reports for certain chromosomal faults like trisomy 18 arising from translocation of chromosome 18. There have been few case reports which have shown that NIPT has some limitation. Yes, so that's why I said accuracy and specificity is way high. It is not 100%. And again, if you get a positive NIPT, you need to confirm it by amniocentesis and CVS. But again, if you compare it with the traditional maternal serum markers, like 90% and this being 99.78% and above, so there is, you're decreasing a lot many false positives and you are avoiding a lot many unnecessary invasive procedures. Right. So that you're avoiding. So that is the advantage. Yeah. So like studies show that for one positive NIPT that is obtained, like 200 unnecessary amniocentesis are being avoided if you compare with the serum markers. So that's a huge statistics. Yeah.
So that's great. That's great. It's so important. My last question to you is, what role does genetic counseling play in conjunction with newborn screening of rare diseases?
Yeah. So this is very, very important question because it's the link. Yeah. So if how you define a genetic test. So this is very interesting. So the definition of genetic testing is incomplete without pre and post test genetic counseling. So that's the part and parcel when you're administering a genetic test. Yeah. So when you are talking in terms of doing genetic counseling with NBS, it is important because if you're administering any genetic test, like say NIPT during pregnancy, or postnatally you're administering any genetic screening test for say any rare diseases, then administering pre-test genetic counseling becomes very important so as to counsel the couple, make them understand what test we are administering to the child, what is the indication, what is the rationale, what is the reason, what is the scientific reason behind it, and what could be the probable outcomes and what it could mean. So, providing all the information beforehand and what could be the probable scenarios post test. So, all this information is given beforehand, and then the couple can decide whether they want to do a test or not. So, counseling is non directive. We give them the information, you let them decide. So most of the cases it is non-directive. In certain situations where, like, suppose family history is strong, or from therapy point of view a genetic test becomes very important, in those cases it is directive. But in situation like this, it is non-directive. You give the information to the couple and then let them decide. The next part is the post-test. Once the reports are there, you have the reports at hand and you discuss the reports, its implications, and you make them understand and simplify the reports for the parents. So post-test counseling. So if you're thinking of newborn screening with respect to screening for the rare diseases where genetic tests need to be done, yes, genetic counseling is going to have a very important role to play.
Right. So that was very insightful, and a technical knowledge with what we have got is so important. So with this, we come to the end of this episode. Thanks, Dr. Anoop. Thank you all for tuning in. Thank you.